Hi friends, I welcome you all for this session.
In this part of video, we are going to focus on morphology, placental thickness, and variations in ultrasound echogenicity. In this slide, we will discuss the early development of placenta. At around 7 days after fertilization, the blastocyst attaches to the endometrial epithelium, usually at the embryonic pole. The outer trophoblast layer, which is derived from the ectoderm, will differentiate into two different types, that is syncytiotrophoblast and the cytotrophoblast. The syncytiotrophoblast is highly invasive. These cells penetrate the maternal endometrium, eroding the connective tissue and maternal capillaries, and thereby initiating the formation of lacunar networks. These lacunae represent the primordial spaces that will later become the intervillar space of the placenta. In contrast, the cytotrophoblast will proliferate to provide stem cell column that will give rise to primary chorionic villi. Now, as the chorionic sac enlarges, the villi will proliferate extensively in the area of decidua basalis, forming a dense chorion frondosome, which subsequently will develop into the definitive placenta. Whereas the rest of the area, the villi will undergo atrophy. This is important to note that although villus architecture is established early, the actual maternal intervillus blood flow is not fully established until after 12th week of gestation. So at this point of time, a low impedance uteroplacental circulation begins to support the pregnancy. By 10 weeks of gestation, placenta can be clearly visualized on transabdominal ultrasound. It typically appears as a thick echogenic rim of tissue surrounding the gestational sac. As you can see in the first image on the left, the two arrows represent the hyperechogenic structure that is beginning to appear as the placenta. Between 12 to 16 weeks, progressive changes occur. The chorion and the amnion gradually fuse, and by around 15 to 16 weeks, this fusion is usually complete. By this time, the placenta is well formed and an important sonographic feature will begin to appear. This is nothing but the retroplacental hypoechoic zone, also referred to as retroplacental clear space. This is clearly seen in the image on the extreme right, which represents the decidua and underlying myometrium and the maternal vessels. This retroplacental space usually measures between 1 to 2 cm in thickness, and it is a very important landmark for assessing the normal placental attachment. Anatomically, the fetal side of the placenta is called chorionic plate, whereas the maternal side is called the basal plate. When evaluating the placenta in first trimester, it is critical to examine its echo texture. Any abnormal findings such as masses, multiple cystic spaces, or any large subchorionic hematoma, especially if it is more than 5 cm, it should be reported and documented and also followed up. Along with the echo texture, it is also important that you report about the location of the placenta if it is anterior, posterior, or to the left lateral or right lateral wall. Here I would like to stress upon one of the important practical point in the assessment of placenta in the early pregnancy or first trimester scan is that the placental position should not be reported. This is because the physiological growth and remodeling of the uterus will cause the placenta, which is detected low in the first trimester, to migrate upwards as the pregnancy advances. I think all of you must be aware of this. So for this reason, placenta previa should never be reported in the first trimester scan, according to the ISWOG guidelines too. Instead, if you have to assess the placenta location in relation to the cervix, it is better to be done in the second trimester. When assessing the placenta on ultrasound, the first principle is to align the longitudinal axis of the probe parallel to the longitudinal axis of the placenta. Begin by identifying the upper margin of the placenta, then trace down to evaluate the lower margin. This is especially important in second trimester, where the placental localization becomes more clinically relevant. Usually with longitudinal midline sweep from the uterine fundus down to the symphysis pubis, the placenta can be localized as either anterior or posterior. However, if the placenta is not visualized in this plane, then it must be situated laterally along the uterine wall. So in such cases, rotate the probe into transverse orientation, which allows you to determine the placenta, whether if it is in right or left lateral wall, and you can visualize the entire placenta for its full assessment. On imaging, you may then observe that the placental tissue extends from the anterior to posterior across the lateral uterine wall. This is nothing but the lateral placental implantation. But it is important that we diagnose this correctly. Importantly, when the probe is rotated transversely, it is advised to label the image to indicate the lateral orientation. This practice will provide clarity not only for the obstetrician interpreting the report, but also for any other clinician reviewing the scan later in the course of pregnancy. Also, it will be helpful. And this will help us in having a consistent understanding of the placental location. The next step would be to assess the echo texture of the placenta. We know that the normal placenta appears homogeneous, while there can be hypoechoic or heterogeneous regions with single or multiple cystic spaces with or without vascularity, about which we will see in detail as we progress across this video. Next step would be to assess the retroplacental space. When in doubt, we can also apply color Doppler to confirm the normal vascularity in this space. Finally, don't forget to see the umbilical cord insertion site. We will discuss about the normal abnormal variance in cord insertion in the later slides. In wide-lobed placenta, two equal parts of the placenta are seen, separated from each other at a distance and connected by membranes. The cord insertion can be on one of the lobe or it can be in between them on the membrane. Similar to bilobed placenta, even in succenturiate lobe, you have two separate segments of placenta, but one of the segment is very large and the other lobe is small. Here also both the lobes are separated at a distance and connected together by membranes. Coming to the circumvallate placenta, here the chorionic plate is smaller than the basal plate. Hence the chorion and amnion, when coming around to the fetal surface, they fold back and form a placental shelf at the placenta margin. Ultrasound will be able to image rolling or shouldering of the placental edges on the either side of the placenta. And this has been explained in detail in the part 2 video to differentiate from other intrauterine membranes. In placenta membranacea, nearly the entire membranes are covered with the villi rather than getting confined to one area of placenta. So you will see that there is a thin, not a thick placenta, but rather a thin placenta that is spreading around the entire uterine cavity. This is associated with complications like antepartum and postpartum hemorrhage and prematurity or placenta previa, etc. Now let's move on to the topic of placental thickness. Under normal conditions, the placenta follows a predictable growth pattern. Its thickness increases in proportion to the gestation age, and as a general rule of thumb, the thickness in millimeter roughly corresponds to the number of weeks of gestation. For example, at 20 to 25 weeks, placental thickness is usually between 20 to 25 millimeter. However, a placenta thickness of more than 4 centimeter at any gestation age is considered abnormal and which needs further evaluation. Although there is no definitive cutoff to say thin placenta, some studies says that less than 2 centimeter is considered as thin placenta. The placenta thickness can be reduced, as I have told already. It can either be thin placenta or it can be thick placenta. If it is thick placenta, then it is important to differentiate whether it is homogeneous or heterogeneous placenta, because the etiology may be different for each of them. Therefore, assessing placental thickness is important as it provides clinical clue regarding the underlying maternal, fetal and placental health. While measuring the thickness of the placenta, the measurement should be taken from the retroplacental space, excluding the myometrium up to the inner surface of the placenta. This is the landmark for measuring. Coming to homogenistic placenta, it is usually associated with systemic maternal conditions or fetal disorders. Among the maternal causes, diabetes mellitus is one of the most important cause, which causes the thickness due to swelling of the villus stroma and increased capillary formation and compensatory expansion of the placental surface area to meet the metabolic demands of the fetus. On the fetal side, several conditions may contribute. This include fetal anemia, which leads to compensatory hyperperfusion and villus enlargement. Even the non-immune hydrops, where the placental edema is a part of generalized fetal condition, or fetal infections such as CMV or chromosomal abnormalities, can also be associated with increased placental thickening. In addition, pathogens such as virus and bacteria can directly cross the placenta. This not only allows the fetal transmission but also causes vascular injury, fibrosis, and inflammation within the placenta, ultimately impairing the placental function. The ultrasound images here shows the homogeneously increased thickness of placenta in fetal anemia, and one case with abnormal myelopoiesis in fetus with Down syndrome, and also the congenital CMV infection. When we encounter a heterogeneous thickened placenta on ultrasound, there are several important differential diagnoses that we should consider. It can be associated with cystic placenta, for which the etiology could be complete mole or partial mole or placental mesenchyme dysplasia. Next comes heterogeneously thickened non-cystic placenta, could be because of hemorrhage or because of the preeclampsia. When a patient comes with a history mimicking abruptio placenta, there may be increased thickness of the placenta due to hemorrhage, but we may not be able to differentiate between the echogenicity of the hemorrhage and the placenta, and this may be the reason that ultrasound is not that sensitive enough to diagnose fresh bleeding in abruptio placenta. In some cases of preeclampsia, the placenta may get implanted over a relatively small surface area. This may give an appearance of apparent thickening, reflecting the reduced placental territory, which in turn contributes to the development of the preeclampsia. A thin placenta may arise from several etiology. It can be a marker of impaired placental function, which may in turn restrict the fetal growth. It occurs in the setting of intrauterine infections, or it can also be associated with chromosomal abnormalities. In such cases, the placenta should always be assessed in conjunction with the other fetal features, like for example, there can be additional markers of infection, or in case of chromosomal abnormalities, it can also be accompanied by other structural abnormalities in the fetus. So, placenta has to be evaluated along with the fetus to make a meaningful diagnosis. When we evaluate placental thickness on ultrasound, there can be several pitfalls that can lead to misinterpretation. The first example on the left shows how an oblique section of the placenta can create a false impression of thickening. In the first sector of that placenta appears normal, but in the adjacent oblique section, it looks abnormally thick. This is especially common when the placenta is located along the lateral uterine wall. To avoid this error, it is important to keep the probe aligned with the longitudinal axis of the placenta, and if you have doubt, then rotate the probe transversely to confirm the measurement. The second example demonstrates a placenta that looks abnormally thickened but is actually due to the myometrial contraction. The key to recognizing this pitfall is by noting the difference in the echogenicity. The placenta is relatively hyperechoic while the contracting myometrium appears slightly hypoechoic. A simple repeat scan after a few minutes will show the resolution of the contraction, with the placenta returning to its normal appearance. Now let's look at the third image carefully. At first glance, you might think that this represents either bilobed placenta or a succenturiate lobe. However, this is actually a diagnostic pitfall. What we are really seeing here is the laterally located placenta. You have to carefully notice how one portion of the placenta appears in the anterior wall and another portion in the posterior wall, However, these two extensions are connected by a thick bridge of placental tissue, which is marked by a red arrow there. And this gives the false impression of two lobes, but in fact it is the single placenta draped along the lateral wall of the uterus. So the key diagnostic feature here to differentiate a true bilobed or succenturiate lobe from a laterally positioned placenta is the bridging tissue connecting both. So the careful evaluation of the continuity of the placental tissue will help in avoiding the misdiagnosis. Finally, the last image shows a case of apparent thinning of the placenta in the setting of polyhydramnios. Here, the excessive amniotic fluid exerts pressure on the placenta, compressing it against the uterine wall and giving the false impression of the thin placenta. This image demonstrates a case of chorioamniotic membrane separation. Under normal condition, as we have seen already, the chorion and amnion fuse between 12 to 16 weeks of gestation. And when this fusion fails to occur beyond 16 weeks, the condition is termed as chorioamniotic separation. It's a relatively rare condition occurring spontaneously in approximately 1:3,400 pregnancies. On ultrasound, the separated amnion can be visualized floating in the amniotic cavity distinct from the chorionic surface. We have prepared a separate detailed video on chorioamniotic separation, which I recommend you to watch. That video will not only explain about the pathophysiology of this finding, but also we will cover all the differential diagnosis of membrane seen within the uterine cavity, so which will help you in distinguishing true chorioamniotic separation from the other mimicking conditions. Now let us move on to the important topic of sonolucencies within the placenta. Sonolucent or hypoechoic areas in placenta are relatively a common finding on ultrasound, and its significance depends upon the location, morphology and associated features. In this session, we will systematically explore the differential diagnosis of placental sonolucencies and their pathophysiology and key sonographic features to confirm the diagnosis, and also finally the clinical implications of them. In this slide, I am going to describe about the normal placental development across the gestation age and how the spiral artery is remodeled and in what way they are responsible for the formation of sonolucencies in the placenta. During the early pregnancy, at the time of implantation, the blastocyst attaches to the maternal endometrium. By around 7 to 9 days after fertilization, the trophoblast differentiate into sensitive trophoblast and cytotrophoblast. As we all know, that sensitive trophoblast invade the endometrium and forms lacunae, and cytotrophoblast will serve as the important stem layer for the villus development. Therefore, in this first trimester, the uterine spiral arteries are plugged by the extravillus trophoblast. These plugs are important to prevent the maternal blood from entering the intervillus space at this stage. Therefore, the conceptus depends on histiotropic nutrition, that is, the secretion from the decidual glands and diffusion across the chorionic cavity, and it derives nutrients from the secondary yolk sac also. This protected low oxygen environment is critical for organogenesis during this period. Now the next step is conversion of this histiotropic nutrition to the hemotrophic nutrition. So by around 11 to 12 weeks of gestation, these trophoblastic plugs dissolve, and the maternal blood is now able to flow into the intervillus space, making the transition to hemotrophic nutrition, where the oxygen and nutrients are derived directly by the maternal circulation. Now let's move on to the spiral artery remodeling. Why it should happen? This is because the ability of the maternal blood to enter gently rather than destructively depends upon this spiral artery transformation. Now, what are all the steps or the cells involved in this process are: maternal immune cells, especially the decidual natural killer cells, accumulate around the spiral artery. They secrete the growth factors and proteolytic enzymes that will loosen the vessel wall and degrade extracellular matrix, and that will lead to the vessel dilatation. The next type of cell is the extravillus trophoblast, and they invade by two pathways. One is interstitial extravillus trophoblast that penetrate the vessel wall from outside, and the second one is endovascular extravillus trophoblast that will migrate into the lumen. Initially, they are the ones that are responsible for the formation of the plugs in the early gestation, and then later they migrate along the lumen and they replace the endothelial cells and also destroy the smooth muscle cell. Now, after all this, the spiral artery gets converted from a narrow contractile tube into wide, flaccid and low resistant conduits. Normally, this remodeling extends only to the inner third of the myometrium, including the highly vasoreactive myometrial segment. Therefore, these changes converts and ensures that the segment most responsive to steroid hormone is remodeled while the invasion stops at its physiological limit. Now let's see the adaptations in the uterine and arcuate arteries. Interestingly, the trophoblast does not invade radial, arcuate or uterine arteries. Yet these vessels undergo major adaptation. By as early as 6.5 weeks, the uterine artery is doubled in diameter. Unlike most vascular beds, the uterine circulation widens as it approaches the placenta. By mid-pregnancy, arcuate arteries can exceed the uterine arteries in caliber, and by term their diameter may be as twice as large. Doppler confirms this adaptation with higher peak systolic velocity and PA index in uterine arteries when compared to the arcuate vessels. So far we have seen that the spiral artery undergoes major transformation, and even the radial, arcuate and the uterine arteries undergo dilatation during pregnancy. Now let's see what is the change that happens after this adaptation. In normal pregnancy, the distal spiral artery widens from 0.5 mm to up to 2 to 3 mm. This dilatation reduces the velocity of maternal blood entering the intervillous space to just around 10 cm per second. This slowed inflow has enough momentum to reach the central cavity of each lobule, from where it disperses evenly throughout the villus tree, as you can see in the picture on the left lower side, and the transit time through the intervillus space is 25 to 30 seconds, providing adequate opportunity for efficient oxygen exchange before draining into the uterine veins. This system is finely tuned to get the maximum oxygen delivery while minimizing the shear stress on the fragile villus structure. The next question is why the upstream adaptation of dilatation of vessels takes place. It is a compensatory response to increasing blood volume of maternal blood that is delivered to the placenta. Due to this increasing volume, the uterine artery, arcuate artery and radial artery all become dilate and they become tortuous too. This will ensure that despite increase in blood volume, the velocity of the flow remains low by the time it reaches the spiral arteries. So it's a nature's way of buffering the circulation so that the maternal blood enters the intervillous space gently, protecting the villus structure from damage and allowing efficient oxygen exchange too. Now let's move on to the failure of this remodeling leading to pathological hemodynamics. When the spiral artery conversion is defective, as seen in the early onset preeclampsia or fetal growth restriction, the distal segments remain narrow or muscular. The blood then enters the intervillous space at around 1 to 2 meters per second. This is almost 10 folds higher than the normal. So these high velocities create a turbulent flow known as hose effect, and it is visible on the ultrasound as jet-like turbulence. This can be seen in the picture as we have given here. Now what is the consequence of this high velocity turbulence jet flow? It may lead to villus rupture and displacement, damaging the anchoring villi. So this can in turn lead to syncytial debris and trophoblast microparticles to dislodge and gets released into maternal circulation. It can activate the endothelial cells, and which in turn can contribute to maternal inflammation and preeclampsia. The shortened transit time due to the high velocity is approximately around 1 second, and therefore this impairs the oxygen exchange even if the overall blood volume is unchanged. And this can be confirmed by analyzing the uterine venous blood, which will have high oxygen content in this scenario, and this indirectly reflects that there is inefficient transfer of oxygen. The retained smooth muscle in the spiral artery leaves them more prone to vasospasm, and then ischemia. Once again, reperfusion injury. So the cycle of ischemia and reperfusion injury happens, and this amplifies the oxidative stress in the placenta. There are two types of blood flow within the intervillous space. First, let us look at the laminar flow. In this mechanism, the maternal blood enters through multiple spiral arteries in a smooth and layered manner. The blood spreads evenly with very little turbulence. Several factors can contribute to this laminar pattern. For example, when there are more spiral arteries producing greater number of gentle entry points, the flow distributes more evenly. In other situation, if there are few draining veins, then the turnover of blood can be slower, and this can also lead to a smooth laminar fashion. Another possibility is presence of physiological venous fistula effect in the basal plate, where the venous pressure is higher than the intervillous pressure, leading to the pooling of blood. On ultrasound, the laminar flow is usually seen as slow, gentle streaming or swirling movement within the placental lakes, and this is typically benign and is associated generally with the favorable prognosis. Next, we are going to move to the pulsatile flow. This occurs when the large spiral artery drains directly into the intervillous space. The blood then enters with high pressure and high velocity. As a result, turbulence and pressure surges are created. So, these jets will displace the anchoring villi, as we have seen already, and then it can cause rupture of the basal plate also very rarely. And this disruption may cause bleeding in some situations. On Doppler, we can see the pulsatile flow, strong pulsatile jets entering the intervillous space, and then in such cases we have to look for the pathology leading to this turbulent flow. Now let us look at the placental lakes. Placental lakes appear as homogeneous anechoic area, that is black color fluid filled spaces within the body of placenta. They are usually surrounded by normal placental tissue and are typically more than 1 centimeter in diameter. And inside them we can find slow swirling movement of maternal blood. On ultrasound, their appearance is quite characteristic. On grayscale imaging, they appear as anechoic and they are compressible when you apply gentle probe pressure. On color Doppler, you can appreciate low velocity and swirling and or turbulent flow within them. Another important feature is that their size and shape may change dynamically depending on maternal position, uterine contraction, or probe pressure during scan, like what we have seen already. You can commonly find this placental lake in the center of the lobule or cotyledon, or directly under the chorionic plate, or along the margin of the placenta. In uncomplicated pregnancy, placental lakes do not cause any structural damage to the villus tissue around them and are not considered to be pathological. However, if placental lakes are associated with secondary lesions like intervillous thrombosis or fibrin deposits, then we have to think of maternal vasculopathy or placental malperfusion that is leading to this placental lakes. Small and isolated lakes are benign and only need third trimester reassessment. However, if there are multiple lakes and large placental lakes more than 4 cm and when associated with thickened placenta, this may require serial growth assessment and then weekly surveillance in specific cases when required. In this slide, let us see the spectrum of placental lakes, their sonographic appearance and their clinical significance. In picture 1, in image A and C, you can see multiple placental lakes. They appear as well-defined anechoic homogeneous spaces within the placenta. If you observe carefully in the hypoechoic area, you can see few gray patterns suggesting swirling of maternal blood flow. Look at the image B of picture 1 and compare this with picture 3 and picture 4. They all will appear similar. They are nothing but subchorionic placental lakes. These are often associated with intervillous fibrin deposition, and flow inside them is typically sluggish or of very low velocity. Such large or clustered subchorionic lakes are not benign until proved otherwise. They have been linked to microinfarction of basal plate, diffuse intervillous fibrin deposition, and secondary lesions of placental malperfusion. Hence, it is better if we follow the maternal Doppler and rule out fetal growth restriction, and also if we have these patients under serial follow-up. So let's move on to image D of picture 1 and picture 2. All 4 images in picture 2 belong to the same patient. This type of placenta is generally described as jelly-like or dirty-looking placenta as per Professor Evesville. This is a thick heterogeneous placenta with spongy and irregular echo texture. Such placenta may be associated with diffuse basal plate microinfarction or generalized intervillous fibrin deposition. There can also be turbulent maternal jet dislodging the anchoring villi, as we have discussed already. Such jelly-like placenta is strongly associated with early onset preeclampsia, severe IUGR and adverse perinatal outcome. Hence, it warrants close maternal and fetal monitoring. In this picture, you can see almost like a small hole in the center of the placenta surrounded by a bright halo of tissue. This is diagnostic of intervillous thrombosis. Now let's see what is intervillous thrombosis. Intervillous thrombosis is nothing but maternal blood that has stagnated within the placenta and coagulated. Such coagulated blood will be surrounded by fibrin deposition, which essentially blocks free circulation in that region. This fibrin deposition will also give rise to an echogenic rim or a shell around this thrombus. If they are small and few in number, they are not of much clinical significance. But if they are multiple and extensive, then this will require close monitoring for adverse outcomes like fetal growth restriction or preeclampsia, similar to other cases. To differentiate intervillous thrombosis from placental lakes, they appear as a hypoechoiculation in the center of the placenta surrounded by echogenic rim, which is nothing but the fibrin deposition. And these intervillous thrombosis are firm, static. They don't change their shape with change in position, and they are not compressible with probe pressure, and you will not see any swirling of maternal blood inside them. The pathophysiology behind lacunae is the high feeding vessels from the maternal side will disrupt the anchoring villi, leading to formation of cystic space filled with high velocity blood flow. Placental lacunae are deep, anechoic and large spaces, generally irregular and ellipsoid in shape, located more towards the basal plate. It is not compressible with the probe pressure. It is generally caused due to the high velocity feeder vessel flow. When you see in the Doppler, the velocity of the blood flow may be more than 10 cm per second. And the clinical significance of this is when you see multiple lacunae with high velocity flow, it can be a strong marker for placenta accreta spectrum, which we will be discussing later.
Thank you so much for watching. If you like this video, please subscribe and share to your friends.